Okay, I thought I would just take a few minutes to go over the notes on page 4 and 5 with you. Uh, Maybe it will be helpful. So with inhalation, the mechanics of breathing, basically what we're looking at is we're looking at using muscle to change the volume of the thoracic cavity. And when the volume changes, if we know Boyle's law, we know that the pressure will change. And so with inhalation, what happens is the diaphragm contracts. And when the diaphragm contracts, because it's a dome-shaped muscle, it flattens out. Okay, so it becomes flatter. It pushes on our abdominal organs. And there are other muscles that could contract too, like the external intercostal muscles, which are the small muscles in between the ribs, or sternocleidomastoid, um, could elevate the thoracic cage. But at any rate, muscle contraction is going to increase the volume of the thoracic cavity. And when the volume of the thoracic cavity increases, the intrapulmonary pressure, or the pressure inside of the lungs, will decrease. And what we need is, if that pressure decreases below atmospheric pressure, that's all we need. Then air is going to move from the atmosphere, the higher pressure, into the lungs, the lower pressure. Okay, air will move passively from the area of high pressure into the area of low pressure. The lungs become inflated, and that is inhalation. There is something called a Herring-Bruer reflex, and all that means is that we have stretch receptors in the lungs that feed into the brain, so that when our lungs are inflated, it inhibits further inflation. And so we can't overstretch our lungs. You can't inhale until, the alveoli pop like a balloon. That's impossible. So that reflex just prevents overinflation. Now, as far as exhalation, that's much more passive than inhalation. Because with inhalation, you have to contract muscles, right, to make the volume of the thoracic cavity increase. But to cause the thoracic cavity volume to decrease, really you're just looking at everything going back to normal. So if the diaphragm relaxes, it becomes more dome-shaped again, right? It's going to jut back up into the thoracic cavity. And we know that our lungs have elastic recoil. And just as a reminder of that, taking a look at this picture from our book, which shows us alveoli, we can see that each alveolus has a capillary bed that surrounds it. And in yellow, they're showing us elastic fibers. And so that's what I'm talking about with the elastic recoil. When you inflate the alveoli, it stretches those elastic fibers. So they naturally just want to spring back to where they were. Also, we talked about surface tension. Surface tension is the attraction of water molecules. The water molecules want to stick together. They don't want to increase their wet-dry interface. And so when the lungs are inflated, that increases the wet-dry interface. And so that's going to increase the surface tension. The alveoli just want to go back to the way they were. And so when these areas kind of spring back to their original state, that's going to decrease the volume of the thoracic cavity. And if we decrease the volume, that will increase the pressure. That increases the intrapulmonary pressure. And all you have to do is increase that pressure above atmospheric pressure. And that's going to force the air to passively move from the lungs out of the body. And so expiration or exhalation it's very passive. It's just everything springing back to normal. It decreases the volume of the thoracic cavity. That increases the pressure on the air in the lungs, and it forces that air out. And then just like inhalation, we could use additional muscle for exhalation, internal intercostal muscles, which are also little muscles in between the ribs, or abdominal wall muscles. Like, for instance, if you were blowing up a balloon or blowing out candles on a birthday cake, something like that would be, additional expiration. And so as far as various factors that affect ventilation, I just have a short list here, and I wanted to mention these briefly. Resistance is definitely a factor to take into consideration. Airflow is inversely related to resistance. So we've looked at blood flow and resistance in the last unit. And with airflow, what happens is, if the diameter of the airway is big, then the resistance is low, right? Air can move in and out easily. But if the diameter of the airway is restricted, if it's small, that's going to increase resistance, and that's going to decrease ventilation. So there are different factors that affect resistance. I just want to mention it here in general. I also just want to mention, what is compliance. Compliance is the distendability, or the elasticity of the lungs. So for instance, when we inhale, our lungs are not very elastic, right? They're stretched to their limit. But they have working elastic fibers which force the air out. So in a disease like emphysema, where compliance is limited, what that means is that these elastic fibers are kind of shot in emphysema. So when you inflate the lungs, you don't have that elastic recoil that forces the air back out. And so you can imagine it's very hard to force that air back out if you don't have good compliance. And then we talked about surface tension again already. For us, we have a substance, hopefully you remember, called surfactant that is going to alleviate the surface tension. So that shouldn't be, a big factor for us. But if you think about a premature infant, an infant that's born prior to them producing their own surfactant, then this would be a major factor. It could actually, shut down ventilation. So surface tension could be so great that you can't overcome it, like in the case of the premature infant. But luckily, we can give surfactant as a treatment and alleviate that for them. But I just wanted to tell you that as an example of where this could be a big factor.